Hey everybody, it's Dave Cameron. So I opted to speak on and share on diabetic ketoacidosis. Diabetic ketoacidosis is characterized by highly elevated blood sugar. This is usually in excess of 250 mg per deciliter and a metabolic pH of less than 7.35. Remember, the normal range is 735 to 745. So less than 735 is going to be metabolic acidosis. Common symptoms that are noted here on the awesome graphic I picked include frequent urination, abdominal pain, confusion, fatigue, dry skin and lips and mucous membranes, a flushed face, and deep and rapid respirations known as Kussmaul's breathing. Um, this is truly one of those things. Once you've seen it in real life, you'll never forget it. It's pretty amazing. I have a little random fact down at the bottom of this slide. The highest that I've ever seen personally, and I've heard of much higher, but was a guy that was over 1,300 that shuffled his way into our emergency room where I used to work in Idaho, and he was in bad shape. So um, causes of DKA often are obviously diabetes, and generally poorly managed diabetes, or it can be the first event as someone becomes diagnosed with type 1 diabetes mellitus. Um, Ultimately, DKA arises from a lack of insulin and just an inability to cope with the amount of sugar that they've got in their system. So, uh, so some counter regulatory hormones that are excreted to try to deal with this can actually make it worse as the body tries to correct itself. But these include glucagon, cortisol, your catecholamines, and growth hormone, which I didn't know that. But as these hormones are released, it's like swinging the pendulum. They can swing it back too far the other way and actually make things even harder on the body. So, the pathophysiology of DKA is actually fairly simple, but also fairly complex. As I said before, it's defined by uncontrolled hyperglycemia and metabolic acidosis, elevated ketones. It is a life threatening complication, and again, usually seen in type 1 diabetes. It's insulin deficiency. And basically, as you begin to build up this very high serum glucose, your body becomes acidic, your pH level drops, your body tries to compensate. Again, you're releasing all of these extra hormones to try to fix that, and uh, these patients become very, very sick uh, pretty quickly. And so DKA presents differently in different people, and this is why multiple common pathologies can mimic the diagnosis of DKA. It is requisite that the diagnosing provider consider the following differential diagnoses when DKA is suspected. So HHNK, anorexic ketosis, myocardial infarction, because they can present, as pale and diaphoretic, usually pale and diaphoretic, but also with horrible abdominal pain and discomfort, body aches. So it could mimic a heart attack. Pancreatitis, as they come in with a really bad stomach ache. The pancreas is angry, and that can certainly be part of it. Alcoholic ketoacidosis, lactic acidosis, sepsis, a diabetic medication overdose, and uremia. So just to name a few, these are some of the things that can mimic DKA. So treatment for DKA, and this is something that I really enjoy, but um, is initially it's hydration, and I'll probably bore you guys a little bit with this, kind of recounting my paramedic days. But when we used to pick up a patient when I was on the ambulance that had high blood sugar. Most glucometers, if it's in excess of 500, it just reads high. And so if we ever had somebody that was high, and really over 200, 250, but if they read out as high, we would start two of the biggest IVs we could get, like legit 16 gauge IVs. If we were feeling especially spicy, maybe even a 14 and a 16, and we would pour on the fluid. And realistically, we were only going to have that patient for, you know, 20 minutes, maybe 30 or 40 minutes, depending on our drive time. And so, that wasn't a bad call. We were trying to dilute the sugar, trying to help their kidneys have a little more fluid, to mobilize and excrete the excess acid and sugar that help with their pH, right? And so as I moved into flight and I began to have patients for a much longer period of time, and learning more about nursing medications, as I was partnered with a nurse, and my scope of practice was drastically increased. Um, I started to learn that, obviously we've got insulin, and my nurse partner would usually manage the insulin, but we give insulin to manage the acidosis. It's not necessarily to correct. I mean, it corrects the sugar, but you're giving it to correct the acidosis, which was an interesting concept, and it kind of a little bit of a mind bender there. Um, but I'm kind of rambling, so I'm going to come back to my slide here a little bit. So, hydration is important. Aggressive hydration. So again, we weren't wrong the way we were doing it for our short period of time on the ambulance. The little bit longer time that I had people, we were giving insulin, again, used to reduce the metabolic acidosis, not necessarily the blood sugar. But with their potassium, as serum glucose is reduced, potassium will fall as well. And potassium must be monitored closely during treatment. Magnesium and phosphate, hyperglycemia and osmotic diuresis usually lead to a depletion of phosphate and magnesium. Insulin can move these electrolytes into the cells, which increases their relative depletion. So they may still be within the body, but they're inside the cell and they're not doing their job out in the extracellular space where they're supposed to be. Bicarbonate, and if things get really bad, the patient may go into respiratory collapse, have to be intubated. They need laboratory monitoring, and we have to try to prevent cerebral edema. Now, one of the biggest ways we prevent that cerebral edema is through slowly and carefully reducing that blood sugar. This is why the monitoring of the potassium and the sodium, and then your mag and your phosphate is so critical, and that it must be done methodically and slowly, is so that we can prevent that cerebral edema. The other very real consideration is with the intubation there. If you've got somebody in DKA that is breathing 30 plus times a minute, and they're taking in volumes of 6, 7, 800 milliliters per breath, their minute volume is enormous. And a ventilator won't usually, and that's their body trying to compensate for that metabolic acidosis, right? The ventilator will not match the patient's ventilatory rate, their minute volume. The respirations per minute times the volume of breath in each breath gives you your minute volume. And so it's very difficult. You basically can't replicate that on a vent, and it becomes very, again, critical to monitor the way that you're reducing your patient's blood sugar, acidosis, potassium, and those electrolytes, the mag, the phosphate, and the sodium. That's a little more into the patho and kind of harping on those treatments. So the main way to prevent DKA, really, once you've got a diabetic patient, really and truly the only thing you can do for them is to educate them and help them hopefully be compliant with their medications. whether they're a newly diagnosed diabetic or whether they are old hat, they've been doing this for a long time. They've been a diabetic for years and years, but they get out of their schedule. I've seen this with family members who they get outside of their normal schedule, and next thing you know, their blood sugar is, in the case of my family member, is low. And we're sitting there talking, trying to have a conversation, and realize that, so and so is not answering appropriately. We check his blood sugar, and it's like 35. So we're like, oh boy, he's been driving this for the last 15 minutes. So, anyways, true story and horrifying. So, DKA treatment again must be gradual to correct the hyperglycemia, the acidosis, and the electrolyte imbalances. You must monitor closely, adjust the insulin and fluids and electrolyte supplementation. So again, you have to do all of these things gradually and take your time, provide support, and help your patient through a difficult illness and a difficult syndrome. In conclusion, DKA is a seemingly simple, but at the same time can be complex and a little bit of a delicate thing to manage. You want to do things just right. And I've often said to my wife, I'm like, I love playing with this like human chemistry set to try to make things work right. And I feel like DKA is like one of the, I don't know, most stimulating for my brain. I want to say fun, but I feel like that's the wrong word. But it's one of the most stimulating to my brain pathophysiologies and illnesses to deal with, because of all the little factors that you have to consider, and the ventilations, the electrolytes, the insulin, the fluids, everything. It is a fun disease process to manage. And so if you like being hands-on and doing stuff, yeah, which I do. So, anyways, I appreciate you guys listening, to whomever listened to my my video here. These are my references that are spread throughout, and I appreciate your time. Thank you.